Christine, can you hear me?
I certainly can.
Thank you very much. Thanks, Christine, and good afternoon, and thank you all for participating in today's webinar. We're very fortunate today to have our presentation led by Priscilla Clark as Senior Accountant with Meyer & Stouffer, a certified public accounting firm specializing in federal and state Medicare and Medicaid programs as our presenter today. Priscilla, you may begin your presentation. Christine will now pass the ball. Thank you.
Thank you, Connie. So as Connie has already stated, we will be discussing on today's webinar, Public Health and Clinical Data Registry Reporting, Objective 8 for Stage 3. Okay, so just the learning objectives for today's webinar is going to be understand the Public Health and Clinical Data Registry Reporting requirements for the Medicaid Promoting Interoperability Program. We want you to be able to understand the differences in Objective 8, Public Health and CDR reporting between program years 2018 and program years 2019. We want you to learn about the Arizona's Public Health and Clinical Data Registry Reporting documentation requirements. So the objective for this is the eligible professional is an active engagement with a public health agency or clinical data registry to submit electronic public health data in a meaningful way using certified electronic health record technology, CERT, except where prohibited and in accordance with applicable law and practice. An EP must satisfy 2 of the 5 available measures for this objective. If the EP is not able to satisfy at least 2 measures, the EP may still meet the objective if the EP qualifies for exclusion from all measures the EP cannot meet. An exclusion for a measure does not count towards the total of 2 measures. In order to meet the objective, the EP needs to meet 2 of the 5 measures available. If the EP qualifies for multiple exclusions and there's only 1 available measure remaining, the EP can meet the objective by meeting the remaining available measure or meeting the applicable exclusions. Available measures are measures for which the EP does not qualify for an exclusion. An exclusion for a public health or CDR reporting objective does not require the EP to submit data to the registry. However, the EP must have a qualifying reason for taking the exclusion as shown on a CMS specification sheet and referenced in this presentation. So we're just going to go over some definitions before we dive into just the details of how to meet different measures and exclusions. So jurisdiction. The definition of jurisdiction is general, and the scope may be at the local, state, regional, or national level. The definition will be dependent on the type of registry to which the EP is reporting. A registry that is borderless would be considered a registry at the national level and would be included for purposes of this objective. Production data. Data generated through clinical processes involving patient care. This term is used to distinguish between data and test data, which may be submitted to test electronic data transfers. Bidirectional. This definition only relates to measure 1. The EP is able to receive and display a consolidated immunization history and forecast in addition to sending the immunization record. Active engagement. The EP is in the process of moving towards sending production data to a PHA or CDR, or sending production data to a PHA or CDR. There are 3 levels of active engagement that are outlined on the following slide. Active engagement option 1, completed registration.
Priscilla?
Data.
Priscilla?
Yes.
I think there's somebody that has their microphone not on mute. So Christine, can you see who might not be on mute, because we're getting a lot of background noise? Sounds like it is.
Let me take a look at that, Connie. Just 1 second. Oh.
Thank you, Connie. Do y'all want me? It sounds like
it looks like all lines are muted, Priscilla. I apologize.
No worries. Can you hear me?
Yes, we can. Go ahead, Priscilla.
Okay, perfect. Thanks so much, Connie and Christine. So we're discussing active engagement option 1, which is the completed registration to submit data. It means that the EP registered to submit data with the public health agency or, where applicable, the clinical data registry to which the information is being submitted. You must register no later than 60 days from the start of the PI reporting period. Please keep in mind that 60-day period does include the first day of the reporting period. Registration is, however, allowed prior to the PI reporting period. The EP is awaiting an invitation from the public health agency or clinical data registry to begin testing and validation. This option allows EPs to meet the measure when the public health agency or the clinical data registry has limited resources to initiate the testing and validation process. EPs that have registered in previous years do not need to submit an additional registration to meet this requirement. We will discuss in a few slides additional information if the EP is an active engagement option 1 with Arizona Immunization Registry. If the EP plans to attest to a new public health measure, the EP will need to register with the registry. Here's just a few completion date requirements, and we're going to walk through a few examples of when it's appropriate for certain dated documents for active engagement option 1. Please keep in mind that if you're registering after the start of the PI reporting period, the registration must be no later than 60 days from the start of the PI reporting period. And that 60-day period includes the first day of the reporting period. So as you can see as the first example, the reporting period is January 1st, 2019 to March 31st. The deadline to complete registration for active engagement option 1 is May 1st of 2019. Registration was completed, so this is just an example of what a document could be dated. It would be dated, say it's dated January 2nd, 2019. That's 2 days from the start of the PI reporting period because you're including the first day of the reporting period. And as you can see in the last column, there is a check mark showing that that is sufficient. For the second example, it's the same reporting period. However, in the second column, it has the same deadline to complete, but then the example is showing that the document was dated March 5th, 2019. The second to last column shows that it was 64 days after the start of the PI reporting period, and that is not sufficient because it must be within 60 days of the start. So please keep in mind of if you're in active engagement option 1, you need to ensure that the documentation that you submit during attestation or even during a post-pay audit, that it is within 60 days of the start of the PI reporting period. And again, as discussed on the previous slide, it can be dated prior to the start of the PI reporting period. For the third example, it shows October 1st, 2019 to December 29, 2019. The deadline to complete is November 29th. Say the documentation was dated April 10th of 2019, that's 170 days before the PI reporting period, and this is sufficient to meet the requirements. The last example shows it was the same reporting period starting in October. The deadline to complete is the same as before, November 29th, and say the documentation was dated November 1st of 2019. That is 32 days from the start of the PI reporting period and is sufficient. Active engagement option 2. This is called the testing and validation stage. The EP is in the process of testing and validation of the electronic submission of data. EPs must respond to requests from the public health agency or, where applicable, the clinical data registry within 30 days. Failure to respond twice within the reporting period would result in that EP not meeting the measure. Active engagement option 3. This is called the production stage. The EP has completed testing and validation of electronic submission and is electronically submitting production data to the public health agency or clinical data registry. Please keep in mind that we did go over the definition for production in an earlier slide. So just some general information. EPs who have previously registered, tested, or begun ongoing data submission to a registry do not need to restart the process beginning at active engagement option 1. For example, program year 2018, you were registered and submitting data, so you were submitting data in the production phase in program year 2018. For program year 2019, when you attest to immunization, if you're still in the production phase, you do not have to go back and start registering. You can stay in that production phase because you're still submitting data and you're still in active engagement option 3. The EP may simply attest to the active engagement option, which most closely reflects their current status. A provider can meet the measure by using communications and information provided by a public health agency or clinical data registry to the EP that is reported individually or at the group level, as long as the EP is contributing to the data reported by the group. If an EP is part of a group that submits data to a registry, but the EP does not contribute to that data, the EP should not attest to meeting the measure, but instead should select the exclusion or select a more relevant measure to meet. If in the normal course of his or her practice, an EP does the action that results in data for a registry and is an active engagement to submit to that registry, but simply has no cases for the reporting period, the EP is not required to take an exclusion and may attest to meeting the measure. Okay, so let's go over just some definitions of the different documents that we will be telling y'all to submit depending on your what you attested. EPs are required to upload documentation for each measure. Active engagement documentation, that is the information listed on slide 15 and should be included in all documentation submitted to support active engagement for applicable measures. The exclusion documentation is if the EP attests to meeting exclusion, the EP should submit documentation to support the exclusion. So active engagement documentation, what does that look like for public health measures? It's documentation to support each measure, and it must be submitted during attestation. Documentation could include a screenshot from the CERT, registry letter, or registry emails to support the EP as an active engagement with the applicable registry. The documentation submitted should include the following: the provider or practice name, reflects the EP's level of active engagement, it should be clearly legible, and it should reflect the date requirement was met. And now let's discuss what those date requirements are. Documentation must prove that the EP's level of active engagement was met. Documentation must be dated to show when the active engagement option 1, 2, or 3 milestone was achieved. For active engagement option 1, the completion date can occur before calendar year 2019 if the EP has not progressed and is still in active engagement option 1, but no later than 60 days from the start of the PI reporting period. Please keep in mind on the previous slide, we did discuss those examples and what would be sufficient. So if you're having trouble grasping what dates would be sufficient, just go back and look at those examples and put yourself into one of those scenarios to figure out if your documentation would be sufficient. For active engagement option 2, the completion date can occur before calendar year 2019 if the EP has not progressed and is still in active engagement option 2. Active engagement option 3, the completion date can occur before calendar year 2019 if the EP has not progressed and is still in active engagement option 3. Okay, so let's look at Objective 8, Measure 1, Immunization Registry Reporting. The EP is in active engagement with a public health agency to submit immunization data and receive immunization forecasts and histories from the Public Health Immunization Registry. Immunization data should now flow bidirectionally between the CERT and Arizona State Immunization Information System Registry. EPs must submit doses administered and query ACEs in real time for consolidated records and forecasts of immunization due at the point of care. An EP CERT may layer additional information on the immunization registry forecast and still successfully meet this measure. EPs should ensure that the CERT has a capability to exchange data bidirectionally with the immunization registry. Non-vaccinated EPs can meet the measure if they query and receive results from ACEs and integrate the data into their CERT in accordance with HL7 version 2.5.1. An EP must have reached out to ACEs during program year 2019 or earlier to request bidirectional data exchange. Now, for previously registered EPs who have previously registered with the immunization registry do not need to register again to exchange bidirectionally. Please reach out to the immunization registry once the EP is ready to begin bidirectional exchange, and then EP will move to active engagement option 2, testing and validation. For newly registered EPs, so if you're an EP that is in program year 2019, first starting to register with the immunization registry, active engagement option 1 is only available in program year 2019 for EPs who have not previously registered with the immunization registry. There are two options for EPs registering in program year 2019. First off, the EP can register to submit data unidirectionally. However, once the EP moves through active engagement options 1 and 2, the EP must immediately request to start exchanging data bidirectionally. Or the second option EP can meet it, is the EP can go ahead and request bidirectional data exchange during the initial registration process with APHIS. Access does recommend this option as it ensures that there's no time period where you are just submitting data unidirectionally in stage 3. So we do recommend that an EP goes ahead and requests bidirectional data exchange during the initial registration process. So what are the changes from modified stage 2 in program year 2018 to stage 3? Well, the meaningful use objective number did change. In prior year, it was objective 10, measure 1. Now immunization falls in program year 2019 as objective 8, measure 1. The meaningful use stage changed, and then the data exchange requirement changed as well. As you can see, in 2018, an EP only had to submit data unidirectionally. However, in program year 2019, an EP must submit data bidirectionally. The CERT must be able to receive and display a consolidated immunization history and forecast in addition to sending the immunization record. Okay, so let's discuss the exclusions. An EP may take an exclusion for measure 1 if any of the following applies. Exclusion 1, he or she does not administer immunizations to any of the populations for which data is collected by the jurisdiction's immunization registry during the reporting period. Exclusion 2, he or she practices in a jurisdiction for which no immunization registry is capable of accepting the specific standards required to meet the CERT definition at the start of the reporting period. Or exclusion 3, he or she practices in a jurisdiction where no immunization registry has declared readiness to receive immunization data as of 6 months prior to the start of the reporting period. Please keep in mind for exclusion 2, the Arizona Immunization Registry has the capability to accept the specific standards required to meet the CERT definition. Therefore, an EP in Arizona is not able to meet this exclusion. For exclusion 3, we want to point out that Arizona Immunization Registry has declared readiness. Therefore, an EP in Arizona is not able to meet this exclusion. Any EPs in the state of Arizona, they either need to, if they're testing to measure 1, they need to meet it or claim the exclusion for exclusion 1 if the EP falls into that criteria. Okay, so what type of documentation would we request for immunization registry? Active engagement documentation. You can look back at slide 14 to see the details of what must be included, which is the following. Provider practice name reflects the EP's level of active engagement. The document is clearly legible and it reflects the date requirements that were discussed on slide 15. An example of supporting documentation to meet this measure is on the upcoming slides. Exclusion documentation for exclusion 1, because keep in mind exclusions 2 and 3 are not available for EPs in the state of Arizona. So the documentation for supporting exclusion 1 is explain and document why the EP does not or is not required to provide immunizations in his or her jurisdiction. For example, an EP submits a signed letter on the practice letterhead explaining why he or she does not administer any immunizations. Here's a documentation example, and this is only for purposes of this presentation to show you what might be acceptable. As you can see, this is an email from the registry, from Arizona Immunization Registry, letting the provider know that they are registered successfully as of April 25th, 2016. You can ensure the documentation includes the items listed on slide 14 and is dated appropriately. Here's another example. It is just a template of an example that the Arizona Immunization Registry would send out to providers and would be acceptable as long as it meets the documentation requirements such as the provider name or practice name, has appropriate date, it is legible. And so ADHS did do a presentation last Thursday, which is recorded on the Access website. So I will point y'all to that at the end of this presentation, and these examples were discussed during that presentation as well. Objective 8, Measure 2, Syndromic Surveillance Reporting. The EP is an active engagement with a public health agency to submit syndromic surveillance data. Syndromic surveillance consists of receiving inpatient and emergency department data in a timely manner so that public health can use pre-diagnostic clinical data to understand what is happening in the community. Syndromic surveillance is a public health measure available for hospitals in Arizona. ADHS is not accepting syndromic surveillance messages from EPs. If the EP works at a hospital, he or she is able to contribute to the syndromic surveillance reporting registry. If the EP does not work at a hospital, he or she is not able to contribute data. So what were the changes from modified stage 2 for Program Year 2018 to stage 3 in Program Year 2019? As you can see, the meaningful use objective numbers did change. In the prior year, it was objective 10, measure 1, and now in 2019, it is objective 8, measure 2. The meaningful use stage did change. In 2018, you were testing to modified stage 2, and now all EPs must attest to stage 3 requirements. Okay, so what are the exclusions for syndromic surveillance? An EP may take an exclusion for measure 2 if any of the following apply. The Arizona Syndromic Surveillance Reporting Registry only accepts data from EHs, not EPs, so please keep that in mind. For exclusion 1, the definition is he or she is not in a category of providers from which ambulatory syndromic surveillance data is collected by their jurisdiction syndromic surveillance system. As you can see, an EP in the state of Arizona is able to meet this exclusion because the Syndromic Surveillance Registry is not accepting data from EPs. Exclusion 2. He or she practices in a jurisdiction for which no public health agency is capable of receiving electronic syndromic surveillance data from EPs in the specific standards required to meet the CERT definition at the start of the reporting period. As you can see, an EP in the state of Arizona is able to claim this exclusion. Exclusion 3, he or she practices in a jurisdiction where no public health agency has declared readiness to receive syndromic surveillance data from EPs as of 6 months prior to the start of the reporting period. An EP in the state of Arizona is able to meet this exclusion because the Arizona Syndromic Surveillance Reporting Registry only accepts data from EHs, not EPs. So what documentation would be sufficient? If an EP does work at a hospital and is meeting active engagement option for syndromic surveillance because they're submitting data to the hospital, the documentation must include the provider or practice name. It must reflect the EP's level of active engagement. It must be clearly legible, and it must reflect the date the requirement was met. Examples of supporting documentation to meet this measure is on the next slide. Exclusion documentation for exclusions 1 through 3. And as discussed, EPs can meet any one of those 3 exclusions. And no documentation is required because we do know that all EPs meet this exclusion in the state of Arizona. However, if an EP does want to attest to meeting active engagement, they can provide a similar letter like this that would be given to that hospital that the provider works at. As you can see, the letter is dated, and this is just a template, so it does not list out the hospital name, but in a real scenario, you would have the hospital name and you would have the date at the end of that first paragraph that's there. Okay, Objective 8, Measure 3, Electronic Case Reporting. The EP is in active engagement with a public health agency to submit case reporting of reportable conditions. Electronic case reporting is the automated generation and transmission of case reports from electronic health record to public health agencies for review and action. Okay, as you can see, there were technically no changes because in 2018, this measure did not exist for the Promoting Interoperability Program. This measure was brought into Program Year 2019 for Stage 3 as Objective 8, Measure 3. Okay, an EP may take an exclusion for Measure 3 if any of the following apply. Please keep in mind that the Arizona Electronic Case Reporting Registry is not accepting data from EHs or EPs. Therefore, an EP in the state of Arizona is able to meet any of the following 3 exclusions that will be discussed. Exclusion 1. He or she did not diagnose or directly treat any reportable diseases for which data is collected by their jurisdiction's reportable disease system during the reporting period. Exclusion 2, he or she practices in a jurisdiction for which no public health agency is capable of receiving electronic case reporting data in the specific standards required to meet the CERT definition at the start of the reporting period. Or exclusion 3, he or she practices in a jurisdiction where no public health agency has declared readiness to receive electronic case reporting data as of 6 months prior to the start of the reporting period. As stated previously, an EP in the state of Arizona is able to meet this exclusion, any of these 3 exclusions, because the Arizona Electronic Case Reporting Registry is not accepting data from EHs or EPs currently. Documentation for electronic case reporting. Active engagement documentation. This is not applicable for EPs or EHs in the state of Arizona. The exclusion documentation for exclusions 1 through 3, there's no documentation required because all EPs in the state of Arizona are able to meet exclusions 1 through 3. Okay, Objective 8, Measure 4, Public Health Registry Reporting. The EP is in active engagement with a public health agency to submit data to public health registries. A public health registry is administered by or on behalf of a local, state, territorial, or national public health agency and which collects data for public health purposes. The Arizona Cancer Registry is currently the only state public health registry. There are multiple national registries available. Please, there's 3 options that we point you to try to find a public health registry. You can contact your National Specialty Society. You can participate in the National Healthcare Survey, and now you can see that as a link that would take you to that website. And then there's a list of public health registries under the National Institutes of Health, which you can also click on to see if any of the registries listed there would help you meet public health registry. EPs may choose to report on up to 2 public health registries and have each registry count towards the total of 2 measures required by the objective. An EP may count a specialized registry if the EP achieved active engagement option 3 in a prior year under the applicable requirements of a PI program for that year. Please keep in mind when we talk about specialized registry, we're going to discuss the definition in further detail in a few slides. If a specialized registry is public rather than private, it would be classified as a public health registry. The Prescription Drug Monitoring Program was not an available registry for the state of Arizona in program year 2019. Okay, so what were the changes for public health? Meaningful use objective. It went from Objective 10, Measure 3, to Objective 8, Measure 4 in program year 2019. The meaningful use stage was modified stage 2 in program year 2018. However, EPs are required to test the stage 3 in program year 2019. For public health, in 2018, it used to be specialized, it used to be called a specialized registry. However, that measure has been broken up and split into 2 measures. And right now we're discussing the public health registry, which is Measure 4. In a few slides, we will discuss Measure 5, which also can incorporate some of the specialized registries that were considered and categories underneath specialized registry in program year 2018. So that measure actually split up and went into 2 different measures in program year 2019. But this measure that we're currently talking about is public health registry. Okay, so what are the public health registry exclusions? An EP may take an exclusion for Measure 4 if any of the following apply. Exclusion 1, he or she does not diagnose or directly treat any disease or condition associated with a public health registry in his or her jurisdiction during the reporting period. Exclusion 2, he or she practices in a jurisdiction for which no public health agency is capable of accepting electronic registry transactions in the specific standards required to meet the CERT definition at the start of the reporting period. Exclusion 3, he or she practices in a jurisdiction where no public health agency for which the EP is eligible to submit data has declared readiness to receive electronic registry transactions as of 6 months prior to the start of the reporting period. So what documentation is required for public health? For active engagement documentation, it should include the following: provider or practice name. It should reflect the EP's level of active engagement. Remember, there are 3 different active engagement levels. The documentation should be clearly legible, and it should reflect the date the requirement was met. And you see slide 15, which was discussed previously, for what dates are appropriate. Exclusion documentation for exclusion 1, what should that look like? It should explain and document why the EP does not or is not required to collect public health data in his or her jurisdiction. What should the exclusion documentation for exclusions 2 and 3 look like for an EP? An EP must complete 2 actions in order to find available public health registries or meet one of those 2 exclusions. The EP should in some way document these 2 steps. Determine whether his or her jurisdiction endorses or sponsors a registry, and the EP should determine whether a national specialty society or other specialty society with which he or she is affiliated endorses or sponsors a registry. On a few slides prior to this one, I did point out a few different websites that you can go to try and attempt to find a registry that would be appropriate for the EP attesting. So what are some documentation examples? So this is a documentation from the National Healthcare Survey. As you can see, it is highlighted in that first line, and it's saying that the provider meets the requirements for active engagement, and so then you can use that as support. Okay. Objective 8, Measure 5, Clinical Data Registry Reporting. This is the second measure that Specialized Registry was broken into. The EP is an active engagement to submit data to a clinical data registry. A clinical data registry records information about the health status of patients and the health care they receive over varying periods of time. Clinical data registries typically focus on patients who share a common reason for needing health care. There are multiple clinical data registries available. There may be additional registries that are not included on this list. As you can see, there is a link at the bottom of the slide that takes you to a website that lists multiple clinical data registries that the EP may be able to submit data to. An EP may count a specialized registry if the EP achieved active engagement option 3 in a prior year under the applicable requirements of the PI program for that year. Please keep in mind that specialized registry was one measure that has been split out into 2, as it's a public health registry or it can be a clinical data registry. So in a few minutes, we're going to talk about specialized registry in detail, but to determine whether that specialized registry is a public health registry now or determined to be a clinical data registry, you need to pay attention to the definitions for public health versus clinical data. As it says, if a specialized registry is private rather than public, it would be classified as a clinical data registry. In a few prior slides, under public health, it discussed if it was public, it would be a public health registry. So please keep those 2 definitions in mind when determining whether a specialized registry is public or private. An EP, just keep in mind that an EP only can count a specialized registry if the EP achieved active engagement option 3 in a prior year. EPs may choose to report on up to 2 clinical data registries and have each registry count towards the total of 2 measures required by the objective. Okay, what were the changes? Well, clinical data registry originally in 2018 was Objective 10, Measure 3. Now in 2019, it is Objective 8, Measure 5, and it is under Stage 3. In 2018, it was modified Stage 2. The clinical data registry used to be called a specialized registry. However, as discussed, it is now a clinical data registry or potentially could be a public health registry, because the specialized registry measure was split into 2 separate measures under Objective 8. Okay, clinical data registry reporting exclusions. An EP may take an exclusion for Measure 5 if any of the following apply. For Exclusion 1, he or she does not diagnose or directly treat any disease or condition associated with a clinical data registry in his or her jurisdiction during the reporting period. Exclusion 2, he or she practices in a jurisdiction for which no clinical data registry is capable of accepting electronic registry transactions in the specific standards required to meet the CERT definition at the start of the PI reporting period. Exclusion 3, he or she practices in a jurisdiction where no clinical data registry for which the EP is eligible to submit data has declared readiness to receive electronic registry transactions as of 6 months prior to the start of the reporting period. Okay, so what does the documentation for clinical data registry need to look like? For the active engagement documentation, it should include the following: the provider or practice name, reflects the EP's level of active engagement, be clearly legible, and it should reflect the date the requirement was met. The exclusion documentation for Exclusion 1 should explain and document why the EP does not or is not required to collect clinical data in his or her jurisdiction. For Exclusion documentation supporting exclusions 2 and 3, an EP must complete 2 actions in order to find available clinical data registries or meet the exclusion. And these 2 items should be documented in some way or explained. It should, 1, determine whether his or her jurisdiction endorses or sponsors a registry, and 2, the EP needs to determine whether a national specialty society or other specialty society with which he or she is affiliated endorses or sponsors a registry. Okay, so what does that documentation look like? Here's an example from DARTnet, which is a clinical data registry, where EPs can submit data, and this is showing a date. It's showing a practice name, which has been removed from this example, and then it also is identifying what active level engagement the EP is in. Okay. You need to ensure that the documentation includes the items listed on slide 14 of this presentation and is dated appropriately. That was a lot of information. So what are some of the key takeaways that we want you to walk away from this presentation knowing? So here's some best practices. You want to check the following before reaching out to ADHS contacts listed at the end of this presentation on slide 58. You should, 1, save documentation and communication between the EP or practice and the relevant public health agency or clinical data registry. You should ensure that documentation includes the information on slide 14, provider name, the date that it's legible, and then it shows what level of active engagement the EP is in or practice is in. You should review the information on the ADHS website. As you can see, that is a link that you can click to and will take you to the ADHS website. ADHS is working on updating their website for stage 3 requirements. Please contact ADHS for specific stage 3 questions. You can contact the appropriate registry in a timely manner. EPs may utilize the contact information on slide 58 to request confirmation of the following: the level of active engagement and the date the EP or practice entered applicable levels of active engagement. Okay, so what's the summary of the appropriate documents and what is required? For registration, here's a few options. You can provide email confirmation from the ADHS Public Health MU portal. It can be an email or letter from ADHS with the status, and by status, we're talking about the active engagement level. For testing and validation, the provider can submit email communications with ADHS showing that they're in the process of testing. Make sure that documentation is dated appropriately, of course. It can be onboarding meeting notes. It can be acknowledgments and messages received for testing from ADHS. The acknowledgement comes from ADHS. It can be an email or letter from ADHS with status. For production, which is active engagement level 3, it can be email communication with ADHS when the EP is in production. It can be production acknowledgement of messages received. It can be a submission report, or it can be an email or letter from ADHS with the status of the provider, what level of active engagement they are in. Examples of all the documents listed above were identified throughout this presentation, but also during ADHS public health webinars that was conducted last Thursday. I strongly recommend that after listening to this presentation, you also listen to that one as well, because it discussed the specific registries in Arizona that might be helpful to the EPs. Okay, so what are some common audit findings? Well, all providers that receive a Medicaid PI incentive payment could potentially be selected by Access for post-payment audit. If selected, Access post-payment analysts will conduct a thorough review of the documentation attached to the EP attestation in EPIP to determine if it meets the program requirements. Access may have follow-up questions or make additional documentation requests. So some common audit findings. Supporting documentation does not show the EP or practice name. Supporting documentation does not have the appropriate dates on it. The supporting documentation for Measure 1 does not show that EP is exchanging data bidirectionally, which is submitting and clearing the data. The EP attests to meeting exclusion, but does not have supporting documentation to support that exclusion. Make sure as you're attesting to meeting the measures or attesting to excluding from different measures that you have the appropriate documentation that supports that level that you attested to. Another common audit finding is not uploading the supporting documentation during attestation. Here are some resources. There's the CMS Objective 8 tip sheet at the very top, and if you click on that link, it'll take you straight to that website. There's also the federal final rule for modified stage 2 and stage 3. We also have the ADHS website there for any specific registries in the state of Arizona and what their requirements are for submitting data to one of those Arizona registries. We also have listed the National Institute of Health Registries. We've listed the CDC Public Health and Promoting Interoperability Program, where there's additional information on that website. We also have, as we have for all the presentations with Access, the Promoting Interoperability and ADHS Public Health Reporting Registry presentation, which is listed on Access website. And then this presentation will be listed within the next week or so, along with the FAQ that we may discuss towards the end of this presentation if no one has any additional questions. We have, as you've seen, we have multiple links throughout this presentation of different examples of public health registries and clinical data registries, to make sure to use that information. Here's the contact information. As you can see, a lot of these contacts are for ADHS. So if you are registering or submitting data to Arizona State Immunization Information Systems Registry, there's an email and a phone number if you have a specific question about the immunization registry. Electronic lab reporting is there, syndromic surveillance, the Arizona Cancer Registry, and then also at the very bottom, it shows access for the PI program. If you have any questions relating to your attestation or general questions about the program, feel free to send any questions to the email listed or to call the phone number listed. So now we will talk about any questions that any of y'all have as you've been listening. We'll give y'all a few minutes to put down a chat box, and if there are no questions, I will show y'all the frequently asked question document that we prepared.
Thank you, Priscilla, for sharing that information. Christine, do we have any questions in the chat box?
We have not received any yet, but we'll give folks a few minutes to enter those into the chat box, and we'll be happy to answer those on today's webinar.
Perfect. And just as you're typing in those questions, we do have this frequently asked questions document that will be released to the providers on the Access website. And there's about 30 questions that we have come up with, just questions that we thought the providers might have. So I'm going to just go through a couple of them. And Connie, feel free to interrupt me if there's any questions in the chat box, because I want to answer those questions first. Okay. So question 3, does an exclusion for a measure count towards the total of 2 measures? The answer is no. An exclusion for a measure does not count towards the total of 2 measures. However, if the EP qualifies for multiple exclusions and there is only one available measure remaining, the EP can meet the objective by meeting the remaining available measures or meeting the applicable exclusions. Okay, so just keep in mind that when you're taking exclusions, you need to be careful to make sure you meet the required amount of exclusions and measures. Okay, question 4, which state agency in Arizona oversees the public health reporting program? And I referenced them a lot throughout my presentation. The answer is the Arizona Department of Health Services, otherwise called ADHS, and it promotes and protects the health of Arizona's children and adults and has oversight of the public health reporting for the PI program. If an EP has a specific question regarding one of the Arizona state registries, this EP can reach out to the contacts listed for each registry, and that link will take you to the presentation where we have the Arizona people listed. What determines an EP's jurisdiction? The definition of jurisdiction is general, and the scope may be at the local, state, regional, or national level. The definition will be dependent on the type of registry for which the EP is reporting. A registry that is borderless would be considered a registry at the national level and would be included for purposes of this objective. Okay. What does bidirectional mean? The term bidirectional only relates to immunization registry reporting measure for program year 2019. An EP is exchanging data bidirectionally with the Arizona State Immunization Information System, is able to receive and display a consolidated immunization history and forecast in addition to sending the immunization record. Okay. skip a few. So how does an EP determine whether he or she is an active engagement option 1? The answer is an EP is an active engagement option 1 if the EP completed registration to submit data. The EP will be awaiting an invitation from the public health agency or clinical data registry to begin testing and validation. An EP must register no later than 60 days from the start of the PI reporting period. Registration is allowed prior to the reporting period. And keep in mind, the 60-day period includes the first day of the PI reporting period. EPs that are registered in previous years do not need to submit an additional registration to meet this requirement for each PI reporting period. Okay. How does an EP determine whether he or she is an active engagement option 2? The answer is an EP is an active engagement option 2 if the EP is in the process of testing and validation of electronic submission of data. EPs must respond to requests from the public health agency or, where applicable, the clinical data registry within 30 days. Failure to respond twice within a PI reporting period would result in that EP not meeting the measure. Christine or Connie, are there any questions yet?
Priscilla, no, we have not received any questions in the chat box yet.
Okay, perfect. Then I will keep reading these questions. Thank you. So how does an EP determine whether he or she is an active engagement option 3? The answer is an EP is an active engagement option 3 if the EP has completed testing and validation of electronic submission and is electronically submitting production data to the public health agency or clinical data registry. Okay. If the EP has previously registered, tested, or begun ongoing data submission in a prior program year, will the EP need to restart the process for that registry beginning at active engagement option 1? The answer is no. The EP does not need to restart the process for that registry. The EP may continue to maintain the active engagement option that closely reflects his or her current status. Okay, if the EP is part of a group that submits data to a registry, but the EP does not contribute to that data, is the EP able to attest to meeting the measure using that registry? No, the EP should not attest to meeting the measure using that registry, but instead should select the exclusion or select a more relevant measure to meet. However, if in the normal course of his or her practice, the EP does the action that results in data for a registry and is in active engagement to submit to that registry, but simply has no cases for the reporting period, the EP is not required to take the exclusion and may attest to meeting the measure. Okay, so what documentation must be submitted to demonstrate that the EP is in active engagement with the registry? The documentation supporting the EP is in active engagement with the registry should include the following. The provider or practice name, it should reflect the EP's level of active engagement. It should be clearly legible and should reflect the date the requirement was met. Okay, so when do you need to complete active engagement to meet program year 2019 requirements? Please keep in mind these dates are extremely important and you need to make sure that the documentation you submit during attestation meets the date requirements. An EP must determine his or her level of active engagement and then use the below guidance on when to complete. Active engagement option 1, the completion date can occur before calendar year 2019 if the EP has not progressed and is still in active engagement option 1, but no later than 60 days to the start of the reporting period. And keep in mind that 60 days includes the first day of the reporting period. Active engagement option 2, the completion date can occur before calendar year 2019 if the EP has not progressed and is still in active engagement option 2. For EPs in active engagement option 3, the completion date can occur before calendar year 2019 if the EP is still in active engagement option 3. Okay. What requirements change between modified stage 2 in program year 2018 and stage 3 in program year 2019 for immunization registry reporting? The following changes occurred between modified stage 2 and stage 3. The measure was formerly objective 10 measure 1 for modified stage 2 and is now objective 8 measure 1 for stage 3. Starting in stage 3, the EP must exchange immunization data bi-directionally. Did the EP have to reach out to the Arizona Immunization Registry during program year 2019 or earlier to request bi-directional data exchange? Yes, the EP must have reached out to the Arizona Immunization Registry during program year 2019 or earlier to request bidirectional data exchange. The EP continues unidirectional data exchange with the Arizona Registry until the EP requests bidirectional data exchange with Arizona Immunization Registry. So please keep in mind that the EP is supposed to reach out to the registry and request to move from submitting data unidirectionally to bidirectionally, which is a requirement of this measure. So what about EPs that have previously registered in other program years? EPs who have previously registered with the Arizona Immunization Registry do not need to register again. The EP should reach out, though, to the Arizona Immunization Registry once the EP is ready to begin bidirectional data exchange. And then the EP will move to active engagement option 2, testing and validation. So the EP probably went from, for example, submitting data in production in program year 2018 and then sent an email or called the Immunization Registry and said, hey, I want to submit data bidirectionally. And then they were able to switch over. And they went straight to testing and validation for bidirectional data exchange. And eventually, they would hopefully move from testing and validation to production eventually. Newly registered EPs, so active engagement option 1 is only available in program year 2019 for EPs who have not previously registered with the Arizona Immunization Registry. There are 2 options for EPs that are registered in program year 2019. The EP can register for the unidirectional data exchange. However, once the EP moves through active engagement options 1 and 2, the EP must immediately request bidirectional data exchange. Or the second option is the EP can go ahead and request bidirectional data exchange during the initial registration process with Arizona Immunization Registry. We do recommend this last option because it ensures there's no time period where the EP is not meeting the requirements for immunization registry in program year 2019. Are there any questions in the chat box yet?
Priscilla, we have not received any questions at this time.
Okay, perfect. I'm going to go over just a few more questions. I'm going to skip down to or towards the bottom because I want to discuss public health registry versus clinical data registries and just some of the questions we thought the people listening might have for that. So question 21, what determines whether a registry is a public health registry? The answer is a public health registry is administered by or on behalf of a local, state, territorial, or national public health agency and which collects data for public health purposes. So what determines whether a registry is a clinical data registry? A clinical data registry records information about the health status of patients and the health care they receive over varying periods of time. Clinical data registries typically focus on patients who share a common reason for needing health care. Please keep in mind, as discussed during this presentation, that in program year 2018, it was called specialized registry, and then they split that measure into public health and clinical data registry. So as you're taking maybe a specialized registry like DARTnet that you attested to in program year 2018 and were in active engagement option 3, now you have to determine is it a public health registry or is it a clinical data registry? And those definitions might help you. So is a specialized registry considered a public health registry or a clinical data registry? In modified stage 2 in program year 2019, all public health registries and clinical data registries were included in the specialized registries measure. However, in stage 3, the specialized registries measure was separated into 2 measures, public health and clinical data. If a specialized registry is public rather than private, it would be classified as a public health registry. An EP may count a specialized registry towards meeting the public health registry or clinical data registry measure if the EP achieved active engagement option 3 in a prior year under the applicable requirements of the program for that year. Another question, 24, is an EP in the state of Arizona allowed to use prescription drug monitoring program as a registry? No, the prescription drug monitoring program was not an available registry in the state of Arizona for program year 2019. Okay, I think we just have a few more minutes. If y'all have any questions, make sure to put that in the chat box. Or if you have questions you come up with after this presentation is over with, please feel free to reach out to the contacts listed in the presentation. There are more questions, and as you can see, these last 2 questions for 25 and 26 provide examples of public health registry measures, and clinical data registries. And so those links do take you to websites where they have a list of the possible registries that you can use to help meet one of the active level engagements for either one of these measures. Are there any last minute questions or anything?
We have not received any yet, Priscilla.
Okay, perfect. And I will just bring this up if y'all want to see for the presentation, just the contacts that y'all can reach out to at any time if y'all have any questions after this presentation is over with. And again, this presentation, along with ADHS presentation last Thursday, will be posted to the Access website for anyone that wants to go back, or if you want to share this presentation with anyone else that is attesting to this program. And at this point, I think I will hand this back over to Health Current. But again, if you have any questions, please feel free to reach out to these people that are listed.
Thank you again, Priscilla. Thank you again for all of our participants in today's webinar. Each of you who have registered and participated in the webinar today will receive a copy of the webinar slide deck, as well as any Q&As, including the FAQs that were addressed during the call. The call has been recorded and will be posted along with any the FAQs and any other documents that were specific to the webinar, both on the Health Current and Access website. This concludes today's webinar. Thank you, Access, for participating today, and thank you all for participating. Stay safe out there and have a wonderful rest of your day. Take care.